Dr. Shefali,
Hanji, Hanji.
are we starting?
Yeah, I'm waiting for, okay from Shubham. Then we'll start.
Just once, just 5 seconds.
Yeah.
Yeah, I think we can start it now.
Sure. Okay. So, a very good evening to all of you. And from now, as we shared with all of you that we are starting a webisode series on decoding GI and HPB oncology. So it's an effort by GI HPB division of Max Institute of Cancer Care, New Delhi, and Dr. Nikhil, who is a GI surgical oncologist, and myself, I'm a medical oncologist. So we will be the program coordinators for all of this decoding series. Will it the main theme of this series is basically it is a student oriented session. So student oriented session would mean that it's basically an effort to explain perspective of GI and HPB malignancy from the student point of view, rather than going into nitty gritty and evolving in each of the trials. We would try to uh, discuss the basics and then lead on to the things which are important for a student to understand before coming into the actual practice. Plus, the important point would be we'll be taking each one of site in GI and HPB in a series of session and covering from surgical to medical to radiation and all other nitty-gritties. So I welcome you all, and now I hand over the stage to Dr. Nikhil to take it forward. He'll explain the format and everything, and then we'll move on. Dr. Nikhil, please.
Yeah, thank you, Dr. Shefali. So the idea was that we wanted to bring out a lot of things which cannot be discussed in a didactic lecture. So we thought it will be a small lecture series followed by panel discussion in which we'll talk about practical points. So for want of time, like we should straight away start. And Dr. Mehta, yeah, Dr. Mehta, you're mute.
Yeah, I'll just.
Yeah.
Can you hear me?
Yeah, we can hear you. I just want to tell one thing before that, like if anybody has, this is for like participants, if anybody has any question, they can write in chat box and we'll take it up in the panel discussion or later. Yeah, it's visible.
Oh, okay. So thank you for having me, to participate in this meeting. So I'm a pathologist, and I'm going to talk on the GEP, that's gastroenteropancreatic neuroendocrine tumors, and their clinical applications. So what is a neuroendocrine system? It's a dispersed system of cells present in the central nervous system, peripheral nervous system, and in many organs, including classic endocrine organs as well, including thyroid, for example. Now, these cells, what they have in common is their biochemical ability for amine precursor uptake. So, precursors of amine include dihydroxyphenyl alanine, 5-hydroxytryptophan. They take up these chemicals and decarboxylate them into amines, and these are called as apute cells. Therefore, they're called apute cells. Now, these amines for dopa would include dopamine, 5-hydroxytryptamine, which is serotonin. So, bioactive amines like these and peptides are secreted by the neuroendocrine cells. Some of these are also produced when you have clinical syndromes associated with neuroendocrine tumors. So, what are neuroendocrine neoplasms? These are relatively rare and they comprise a heterogeneous group of tumors. These are characterized by presence of neurosecretory granules, which on immunohistochemistry as pathologists we identify by synaptophysin and chromogranin stainings. And they have very characteristic histology, which a pathologist is easily able to pick it up. So this includes organoid pattern, what we describe, and very characteristic nuclear morphology. Now, NENs can arise at almost any anatomical site, including paraganglia, and these are distributed throughout the body in all organs, all types, including in soft tissues. The term NEN encompasses both a well-differentiated neuroendocrine tumor and a poorly differentiated neuroendocrine carcinoma. They both share common histologic, immunophenotypic, and ultrastructural neuroendocrine features. They're also clinically fascinating because of their hormonal effects and syndromic associations. This got stuck here for some reason. I'm sorry, just bear with me for a minute. Can you hear me still?
Yeah, we can hear you. We
I'm
can
sorry,
hear
my
you very well.
screen's frozen for some reason. It's not. Can I just stop sharing and share again, please?
Yeah, please go ahead.
Yeah, I don't know what the problem is. I'm so sorry for this glitch. It seems to be moving now here. So that's the cartoon of a neuroendocrine cell, the cytoplasm, which is pink here, the nucleus in blue. And these are all cells which are characterized by the neurosecretory granules. They secrete the peptides. And on the surface of the granules sits chromogranin, and there are different acidic chromogranins A, B, and C. Now, these peptides and chromogranins are secreted in the blood, and therefore they act as biomarkers for neuroendocrine tumor evaluation. The neuroendocrine tumors also have small synaptic vesicles, brown here in this picture, and these contain synaptophysin, which is a good marker for neuroendocrine tumors. Now, as I said, there are markers for neuroendocrine differentiation, which include the non-hormonal ones, including chromogranin, the most common being chromogranin A, synaptophysin, CD56. And off late, we have a marker called INSM1, which is insulinoma associated protein 1, which is a good neuroendocrine marker for neuroendocrine tumors. Now, serum chromogranin is elevated where you get very high levels when you have usually the low grade and the lower end of neuroendocrine tumors, so G1 or G2. A moderate or low elevation may also be noted with pancreatic adenocarcinomas. A patient has a renal impairment or the patient is on chronic proton pump inhibitor use. Now, so serum chromogranin cannot be used as a diagnostic test for neuroendocrine differentiation for the above mentioned reasons, but it can be used for follow-up when there is a known low-grade NET. Now, why do NETs require a separate classification? Why are we even having this talk? Clinical behavior varies vis-a-vis carcinomas. In fact, NETs at different sites also behave differently. And we need to predict the outcome and determine the appropriate therapy for a site-specific disease. Now, there are two fundamental aspects to this classification. One is staging, which we all know what it means. And in a tubular organ, what it means is extent of the mural spread, which means how deeply it's invading, and the end status. But most important here is the concept of grading, which is linked to differentiation. Now, differentiation refers to the extent to which the tumor cells resemble their non-neoplastic counterparts. So, well-differentiated NETs are monotonous. They have an organoid growth pattern, and this is all under the microscope. So, it could be nested, gyriform, or trabecular, as we say. And they have abundant neurosecretory granules, and therefore its expression of synaptophysin and chromogranin A is very high. Now, poorly differentiated NETs usually have a sheet-like pattern, which means it's sheet. There is no specific pattern, irregular nuclei, and less cytoplasmic granularity. And this is reflected in limited expression of both chromogranin A and synaptophysin. Now, grade, on the other hand, refers to the inherent biologic aggressiveness of the tumor. So, low-grade NETs are relatively indolent, high-grade NETs are aggressive, and the intermediate grade ones are less predictable and they have a more aggressive course than the indolent ones. Now, how do you assess the grade? It's either by doing a mitotic count or a MIB1 labeling. Now, this is the current way the NETs are described. So you have the well-differentiated NETs, which are low grade, intermediate grade, high grade. It's G1, G2, and G3. And all poorly differentiated neuroendocrine tumors now are called NEC. They are not called G3 because by default, every NEC is high grade. So the current classification says you just call them NEC. There is no need to assign a grade G3 to it. Now, the current WHO 2019 classification clarifies the terminology of NEC versus NET. So NEC is clearly indicative of a high-grade malignant histology and biologic behavior. NET, in contrast, is intended to designate a family of well-differentiated neoplasms whose potential to metastasize or invade its adjacent tissues depends on the tumor site and the grade. But remember that all neuroendocrine neoplasms have malignant potential. So that's the current WHO 2019 classification. NETs are called G1, G2, G3. As I said, differentiation. So if it resembles a parent cell very nicely, it's called well differentiated. The grade, the biologic aggressiveness is low, intermediate, high. And how do we determine this? Usually by doing what we call as key 67 index. When we say MIB1, that's the clone of the antibody. So MIB1 labeling index less than 3%, low. Anywhere between 3 to 20% is intermediate, that's G2. If it's more than 20%, it's called G3, that's a high grade NET. For high grade NECs, it's either small cell or large cell type. They are poorly differentiated. High grade mitotic index more than 20% by definition. In reality, it's almost always 50 to 70%. And there's another concept, what was called as MANEX, that used to say a mixed adenoma, adenocarcinoma, and neuroendocrine carcinoma is now called as a mixed neuroendocrine and endocrine tumor. Now, this is called N neoplasm because the low grade component could be a benign tumor such as a well differentiated NET as well. Now, differentiation varies. It's either well or poorly differentiated. Grade is variable, and MIB1 is variable depending on the lower grade or the higher grade tumor that you have as part of a MINEN. Sorry, I'm still getting stuck with my slides. I don't know why it's not moving ahead. Okay, so that's the grading of GEP NETs. When you do a MIB1 labeling, on the left is a MIB1 labeling index less than 3%. Between 3 to 20% is NET G2, and very obviously high MIB1 labeling index more than 20%. But where the parent, the tumor cells still resemble the parent cell, so it's well differentiated. Therefore, it is NET G3 and not a NEC right now here. So the current system recommends obtaining a MIB1 labeling index as a percentage of about 2000 cells you have to count. Now the recommended recommendation for a mitotic index versus a MIB1 labeling index is to evaluate 50 high power fields and then average it out for 10 high power fields. Now 50 high power fields equates to about a 10 square millimeter area. That's quite a bit of area. So this makes it virtually impossible to count mitosis on FNAC smears or even core biopsy specimens. Therefore, MIB1 labeling index is indicated to assess the grade of the tumor. Now, the question is not only count or not to count, but it's a matter of how to count. So one can either do manual counting. So what we can do is we can take a picture of the high power field and dot the ones which are marked the brown, which is the positive ones, and calculate. Or you can do a estimate by eyeballing or a digital image analysis. In reality, what people do is usually they do a kind of an eyeballing estimate, and that's usually the hotspot which is counted. So per the WHO recommendation, one needs to count the highest proliferative region, that's the area of strongest nuclear labeling, while calculating the MIB1 labeling index. Now, the problem in this is that there's a temporal heterogeneity in the biology of the tumor. Everything is not uniformly 3% or uniformly 5% or 10%. It varies in different parts of the tumor. And because the cutoff between G1 and G2 is so sharp at 3%, that's where the problem arises. G3 is usually never a problem. Now, if you see this article here in ModPath 2012, it said if you have to identify G2 areas in 90% of the cases, they actually did a calculation, it would require 31 core biopsies. Now, that's really practically impossible. Now, additional grading consideration that one needs to consider is that because mitotic activity is to be calculated on a field of 10 square millimeters, it's not feasible on small biopsies. Therefore, one has to do MIB1 labeling. And again, as I said, proliferation can be heterogeneous. So sampling issue can limit accuracy of grading. It depends on where the needle has actually hit the tumor. So sometimes the tumor may be inherently G3, but you would call it G2 because a needle has gone into that area. So this whole concept of heterogeneity arose from the Nordic NEC study in Annals of Oncology, where they said that GI-NECs, that's neuroendocrine carcinomas, that's how they were called that time, with a MIB1 less than 55%, had a lower response rate to first-line platinum-based chemotherapy, and that's the therapy that one would give for a high-grade NEC. But they had a better survival than patients with higher MIB1 labeling indices than these patients. So what was the understanding from that was morphologically well-differentiated pancreatic NETs classified as G3 only and solely by a MIB1 labeling are less aggressive than bona fide poorly differentiated NECs which do not resemble the parent cells. So while we may like to believe that G1 to G3 is a continuum and that grade should be based entirely on the proliferation index, evolving evidence suggests that morphologic differentiation is also relevant, and this is now reflected in the current classification where the NETs are called well-differentiated NETs G1, G2, G3, and the NEC is just called NEC without a G3. Now, basically, wanting you to kind of focus on these things between NET and NEC, the ones highlighted by red. So NETs may show great progression within the same tumor at presentation, or even between the primary and the metastatic sites during the course of progression. Versus NEC, which arises from precursor lesions that typically give rise to non-NECs of respective organs, such as adenomas in the colon and squamous dysplasia in the esophagus. Presence of both low and high grade components within an individual NET is a strong evidence that the high grade component still remains a well differentiated NET. So if you're seeing a G1 NET and a G3 NET, it means that the G3 is still genetically associated with the lower end of the spectrum. Now, NECs do not commonly arise in association with NET, so you don't get NET and NEC together. Pancreatic neuroendocrine carcinomas are usually large cell type and may contain components of adenocarcinoma, typically which you do not find with NETs. Okay, I think again this thing's freezing. Anyway, so NET contains G1, G3, as I said, low grade. So G1, G2, and G3. I'm not able to move. Sorry again for this. Sorry, I'm going to stop sharing again. And I'm really sorry for this. I don't know, the computer's misbehaving today. Okay, so with NET, usually you can get functioning tumors and non-functioning tumors. The ones in pancreas, ileum, and duodenum are functioning tumors. The ileal ones are the ones responsible for carcinoid syndrome. The non-functioning ones include gastric, the ones in liver, bile ducts, and colorectal. NECs are typically non-functioning tumors. NETs have syndromic associations, MEN1 syndrome, usually find tumors in pancreas and duodenum, no syndromic association with NEC. Surgery and medical treatment of NETs is dependent on the site of origin. Chemotherapy is usually the treatment of choice, even in resectable NECs. Now, as far as genetics goes, the poorly differentiated NECs have genetic features that you would associate with pancreatic adenocarcinoma, such as KRAS, CDK, and 2A or SMAD4 mutations. Whereas for NETs, you get MEN1, DAX, ATRX mutations in the mTOR pathway dysregulations. RB and P53 mutations are common with NECs. NECs are genomically unstable versus NETs, which are genomically stable, treated by octreotide or peptide receptor radiation therapy, mTOR inhibitors, TKIs such as sunitinib, and lastly, chemotherapy. The usual treatment for NEC would include a platinum or etoposide-based chemotherapy. Lastly, quickly to wind up and talk about Menin's, that's a neoplasm with both a neuroendocrine component and a non-neuroendocrine component. Each component has to exceed at least 30% of all neoplastic cells. The non-neuroendocrine component may be adenocarcinoma or a squamous carcinoma, or one of the components may not even be a carcinoma. Both components should be graded, and if there is a small cell component, that should definitely be graded because that drives the biology of the tumor. The identification in adenocarcinomas of scattered neuroendocrine cells does not qualify for Mannix or Menin. A lot of pathologists are prone to call things kind of neuroendocrine because there is small amount of synaptophysin positivity. that doesn't make it a neuroendocrine tumor. And for obvious reasons, because you need 30% of each component to be graded, diagnosis of menin is best rendered only on resection specimens. In GI tract and hepatobiliary menins, both components are usually carcinomas. Therefore, the neuroendocrine component is usually an EC. Very rarely, the neuroendocrine component may be well differentiated. Now, non-neuroendocrine component should also be classified and graded accordingly as adenocarcinoma, squamous carcinoma, even an acinar cell carcinoma of the pancreas could be part of a menin. So it's the higher component of the neuroendocrine differentiation which drives the biology of the tumor. And if you have a mixed component of adeno and NEC in a pancreas, for example, it's the NEC which will drive the biology of the tumor. Very importantly, nowadays in the days of neoadjuvant chemotherapy, once you give that, neuroendocrine morphology might be exhibited by some treated carcinomas. It could either be post chemotherapy, post molecular targeted therapy, or radiation therapy. So these should not be called as mixed neuroendocrine tumors. Now, how do you call something malignant in a neuroendocrine tumor? It has to invade the muscularis propria, except in appendix where it's the mesoappendix and not the muscularis propria of the appendix, or adjacent tissue, or if you get a metastatic disease. Malignancy will not depend on the morphology. Even a well-differentiated NET could be malignant. So the diagnosis may not always be possible on a core biopsy. And finally, thing on FNAC versus core biopsy is that with FNAC, you can probably distinguish NEC, that's high-grade neuroendocrine carcinoma, from a NET, but you will not be able to tell if it's G1 or G2. For obvious reasons, you can't do a mitotic count or even do a MIB1 labeling. However, the core biopsy affords more tissue, a higher comfort level in terms of diagnosis and grading, because you can do actually immunohistochemistry and MIB1, and it's good for archiving for future use for doing any immunostains as well. I think that's all that I have. I'm sorry for the glitches that I have encountered and wasted some time. Thank you.
Thank you, Dr. Mehta. I mean, very nice and crisp presentation. So, questions, Dr. Nikhil, should we take questions? Few questions now from Dr. Mehta, because he will not be available.
Yeah, there's only one question. You can take that.
Yeah. So, is there any question in the chat box?
Yeah, there is one, I'll tell you. So there is one question from Dr. Manish Jain, and he is asking, Dr. Manish Jain is our dear colleague here only, and he is asking what is the difference between menin and manic?
So manic, the name has been replaced by menin now.
Yeah.
And because the WHO recognizes that you don't always have to have a carcinoma component in the definition, therefore they made it a mixed endocrine, neuroendocrine neoplasm. It's N now. That's the only difference. No other difference.
Sorry, if I can correct you, Nikhil. What Manish wanted to ask is, what is the difference between a menin versus adenocarcinoma with neuroendocrine differentiation? Are these two entities, or are these two different entities? And how do you differentiate between the two?
Yes. So as I said in the definition, you need to have 30% of each entity. So if you have, say, 30% of the tumor is adenocarcinoma, and at least 30% of the tumor is neuroendocrine tumor, then only you can call it menin. Isolated synaptophysin-induced neuroendocrine differentiation does not make it a menin.
Yeah. So in that case, if you have a less than 30% element of neuroendocrine variation, you would probably call it as adenocarcinoma with neuroendocrine. So it's the amount of tumor tissue you have there, right?
So slightly off the kind of talk here, but the right-sided colonic tumors very frequently resemble neuroendocrine tumors, even the routine adenocarcinomas, and they will show some kind of synaptophysin positivity. So unless it's more than 30%, please refrain from calling it a menin.
Right. Fair enough.
Yeah.
Thank you so much.
Thank you. Yeah. So now I'll request Dr. Sujoy Pal to speak about surgical aspect of neuroendocrine tumors which are non-metastatic and resectable. Dr. Sujoy Pal is a professor of GI surgery at All India Institute of Medical Sciences, New Delhi. Dr. Sujoy Pal, sir.
Yeah, just a minute. Am I allowed to share my screen?
Yeah, sir, absolutely.
It's
If there is any problem, I have it ready, sir. Maybe I can share
I
it.
think you can put it on because I am not able to.
Okay. Yeah, shared.
Okay. So would I be able to move it? No. You
No,
will be
I
able
will have to
move
do it. You'll have to tell me next slide.
Okay. Right. So I'm supposed to talk about the gastroenteropancreatic neuroendocrine tumors, the surgical management of the localized variety, where we are not talking about occult and the metastatic disease. Okay. Next slide, please. Slide.
Yeah.
So before I actually go into the details of the management, it is important to realize that the GEP-NETs are an interesting group of tumors, and there has been a six-fold increase over the last 2 decades. The last when it was reported was in 2012, which documented this increase. And although we don't have any national data from our country, but the incidence is about 1 to 4 per 100,000 in the Caucasian population. And majority are well differentiated and majority are sporadic. But GI tract is a very common site for its origin, out of which pancreas accounts for around 44% of the cases. The rest is small bowel, stomach, colon, rectum, appendix, like that. And unfortunately, about half of them will have metastatic disease at presentation. Even though they have metastatic disease, they may still have a long-term outcome, which is better than most other tumors that we normally encounter. And the syndromic association, which I've already heard in the previous talk, is very commonly seen with the MEN1 syndrome, where incidentally the neuroendocrine tumors actually determine the long-term life or outcome in these patients. Then the von Hippel-Lindau syndrome, neurofibromatosis, and tuberous sclerosis. What is good about the syndromic association is that often these tumors are picked up earlier, and they usually have a better prognosis if they are treated earlier. But unfortunately, the other problem is that they are often multifocal, and you may not be able to get away with a smaller resection. Next, please. Slide. So these are the some caveats that I took from the NCCN guidelines of this year, 2020, which I would like to reiterate because that's a common theme running through this presentation. The resection of recurrent locoregional disease, isolated distant metastasis, or a previously unresectable tumor that has regressed should be considered for selected patients with adequate performance status. Patients with symptomatic recurrences from local effects of hormone hypersecretion can be effectively palliated by a subtotal resection up to the tune of 90%. But judgment is important in these cases, and it remains controversial to offer this kind of a surgery for non-functional disease. Cholecystectomy should be done at the time of doing a surgery in most NETs because you're anticipating a use of octreotide therapy subsequently. And liver-directed therapies, which is not the theme of our current talk, can cause hepatic metastasis in patients who have undergone pancreatic duodenectomy in the past. Octreotide therapy should be administered parenterally prior to induction of anesthesia if carcinoid crisis or a carcinoid syndrome is associated. And all patients who might require a spironectomy may benefit by a prior vaccine, trivalent vaccine preferably, given before the elective surgery. Slide. So these are the guidelines starting from the stomach. Basically, what you should remember is that there are 3 types in the stomach which fall in the category of neuroendocrine tumors. The type 1 and type 2 are associated with hypergastrinemia, but type 1 is associated with atrophic gastritis, whereas type 2 is associated with the Zollinger-Ellison syndrome. So the treatment varies according to the type of the tumor. And the third variety is the one which is the most malignant, and they are called the type 3 types, and they can often be of the G3-NET variety, along with some other colonic tumors which can also have G3-NET variety. And these are the worst prognosis of the lot. Now, the treatment for small tumors is basically can be treated by observation or by endoscopic resection. And if there are multiple tumors which are functioning, they can be treated with a localized sleeve resection. Whereas in the Zollinger-Ellison syndrome, the target of the treatment is the pancreas, and the duodenum, not the stomach per se. Next slide. So moving on to the jejunum, ileum, and the colon. Ileum is the commonest site of the GI tract, or the tubular GI tract, where the NETs occur. And here again, the occurrence of the carcinoid crisis or carcinoid syndrome is associated with extensive metastatic disease to the liver, because serotonin, which is secreted by these tumors, is easily metabolized by the liver in the first pass. It is only when the liver is replaced by metastatic disease that you have a carcinoid syndrome. But the thing is that it has been shown that for locoregional disease, resection of the bowel along with the adjacent mesenteric lymph nodes is necessary for affecting cure. And what is more important here is, although the TNM classification talks about the size of the tumor as one of the definite prognostic indications, in ileum and jejunum is one part of the GI tract where the size is not directly correlated with the invasiveness. Even a small 4 millimeter tumor in the ileum can be a metastatic tumor, give rise to metastasis. So that is one important thing that you should remember as far as the ileum and the small bowel is concerned. Whereas in all the other areas, size does play a major role, especially in the stomach, the colon, the rectum, and even in the pancreas. Appendix is again a good site, a common site for occurrence of an incidental carcinoid tumor. And many of these remain asymptomatic for a long time. But if they are incidentally picked up during appendicectomy, which happens in, say, around about 1 in 200 to 300 appendicectomies, it is prudent to realize that smaller tumors can be just treated by appendicectomy. But if there is a remnant on the biopsy, or if the tumor is seen to be invading the stalk, that is a mesoappendix, or it is invading the cecum or the base of the cecum, it's better to go ahead with a limited or a proper right hemicolectomy encompassing the mesocolon in that area, which is draining the lymphatics. So that would be the things. And appendix tumors are very often very indolent as opposed to the ileal tumors, and they are the ones who are less likely to be metastatic as compared to the small bowel carcinoids. Looking at rectal tumors, again, the emphasis is on picking up. Many of the times, these tumors can be incidentally picked up and in old individuals. And the smaller tumors need to be treated locally by possibly by endoscopic polypectomy or using endoscopic submucosal resection or the cap variety of endoscopic resection, which would be in all probability the only treatment required for treating these patients. And subsequently, they can be followed up. And once the follow-up doesn't reveal any recurrence, then the follow-up is not necessary. But if you have larger tumors, or if you have a infiltrating feature on the endoscopic ultrasound evaluation, or there is lymphadenopathy associated, you need to treat them just like we do for any other rectal cancers. And for the smaller tumors, you may go ahead with a localized or a minimally invasive resection. But for the larger ones, you may have to undertake a formal anterior resection or a APR as the location will demand. Next. Next slide. I basically taken a few slides from the ESMO guidelines, which have been oncology guidelines, which have been recently published, which just basically reiterates some of the facts that we have already discussed. Surgery with macroscopic radical intent is the mainstay of treatment for small bowel NETs. But when you have a situation where there is metastatic disease, which is again beyond the purview of this talk, you may have to still undertake the resection of the primary if it is symptomatic, or it is likely to cause obstruction, or it can cause ischemia because of the infiltrative desmoplastic reaction, which often small bowel tumors can create. So in those cases, you may have to undertake a resection despite a widely metastatic disease in the liver. And there is a very small group of patients where the Ki67 is less than 10%. It is a grade 1 or grade 2 tumor where the liver metastasis is not locally resectable because it's bilateral and widespread, and there's no other disease elsewhere. You may offer them a liver transplant, but it is a very, very select category of patients where this kind of a therapy will work. Next. So coming back to carcinoid syndrome, again, it's not in the purview, but just to mention that you have to include echocardiography as part of the routine investigation in these patients, because often these patients develop endomyocardial fibrosis on the right, which affects the tricuspid valve on the right side of the heart mainly, and that can actually lead to anesthetic complications, perioperative problems, and postoperatively trouble because of the chemotherapy which is going to be anticipated in these cases. So that has to be a routine part of the evaluation in these patients. And most initially are treated with octreotide, and later on the other additional add-on treatments depending upon the response of the patient to the treatment. Next. Again, we move on to the next slide. So coming to the pancreatic neuroendocrine tumors, a lot has been written about whether we can actually non-surgically manage these patients, especially when they are incidentally detected, specifically because of the increased detection of such tumors on a cross-sectional imaging done for some other purpose. And it has been shown that if active surveillance is practiced for tumors less than 2 centimeters, which are non-functioning, do not have any hormonal sequelae, can often be left under active surveillance without operation, specifically in those patients where there are no additional features of malignancy picked up on the CT scan, but they would need regular monitoring with cross-sectional or imaging or endoscopic ultrasound to pick up any change in the size or infiltrating characteristics. Because if that happens, there is a limited number of patients who will shift from the active surveillance group to a resection group. And generally it is offered to those patients who are old, have debility and comorbidities which preclude resectional surgery. In all other situations, it is generally advisable to operate such tumors. You may actually get away with the enucleation in many of these small tumors, but in others, generally a resection with a formal lymphadenectomy. So if it is in the head, it will be a Whipple's pancreaticoduodenectomy. If it is in the tail, it will be a distal radical pancreatectomy with a splenectomy, which is usually recommended for these patients. Next. So this shows the Kaplan-Meier curve that if you do a resection in well-differentiated G1, G2, and even sometimes in G3 tumors, you get a good survival. But if you have a poorly differentiated or a neuroendocrine cancer, it is almost equivalent to what you normally get in other adenocarcinoma cases. But if you do observation without active surveillance, you may have a poor survival. Next slide. This is another meta-analysis, which is actually looking at surveillance versus surgery. And the same thing that I reiterated is actually tabulated and presented in this article from 2017 in the British Journal of Surgery, which says that active surveillance versus surgical management of small non-functioning pancreatic neoplasms is justifiable. Next. Next. Another one which compares enucleation versus standard resection. Many of these small tumors, which are less than 2 centimeters, and specifically in insulinomas, we prefer to do enucleation because insulinomas are less likely to be malignant, and sometimes the non-functioning tumors, which are small, are less likely to have lymph nodal metastasis, and you can get away with the enucleation. But the only problem is enucleation is associated with a high post-operative pancreatic fistula rate, which of course many people have documented that is generally innocuous. Does not have the same connotation as you have a pancreatic leak, anastomotic leak after a Whipple's procedure. So enucleation versus resection for small tumors, equivalent results. For larger tumors, you have to do a formal resection. Next. This is just some steps of enucleation in insulinoma, which was about 1.8 centimeters in size from the pancreatic body. This is the current protocol, diagnostic protocol that we follow for insulinomas in our institute, where most will undergo a multiphasic CT or a MRI, and they are followed by an endoscopic ultrasound. And with this, we are able to diagnose 91% of the cases. The rest are examined on table with an intraoperative ultrasound to perform the adequate resection as the case may be. For larger tumors, we prefer resection. For tumors in the periphery, we enucleate. And if the tumors are next to the, closer to the MPD, we try and avoid doing enucleation. And if required, we'll go ahead with a resection, preferably. Looking at gastrinomas, again, it can be complicated managing these tumors because they often can be multicentric, and some of these tumors primarily have origin in the duodenum or in the wall of the duodenum, and some located in the head of the pancreas. Some of these smaller duodenal lesions, if they are small and can be accessible by endoscope, can be removed by endoscope, and that can lead to cure. But in most instances, you have to do a operative removal. And in the most curative way of doing the surgery is to do a Whipple's pancreatic duodenectomy in these patients, which takes care of the lymph nodal disease as well, and is able to give you good, satisfactory long-term survival in these patients. Next. Looking at non-functioning tumors, I've already given you the gist of what is our philosophy in approaching these tumors. For larger tumors, you need to be radical, which includes the region of interest as well as the localized lymph nodes, which both need to be tackled. Next. This is just an algorithm which elaborates on the pancreatic neuroendocrine tumors. Mostly the resectable ones will need a radical surgery. And in the smaller ones, you can get away with the enucleation. But when you're talking about M1 disease, generally speaking, pancreatic resections are not done unless you're dealing with a symptomatic tumor, in which case a distal pancreatectomy is something which can still be recommended in such cases. But Whipple's also has been occasionally done in symptomatic situations, but you would prefer not to do that. And pancreatic cancers, by and large, the neuroendocrine tumors generally do not form a cohort which is able to be handled by liver transplantation. Most of that is done by small bowel entities, but very few cases of pancreatic neuroendocrine of low grade can qualify for such things in some of the series. This already has been spoken about. I would just like to add that generally the neuroendocrine carcinomas have a Ki67, which is upwards of 50-55%. And that is one of the ways of separating or trying to find out whether we're dealing actually with a neuroendocrine cancer and not a grade 3 NET. Next. Next. So basically, in a poorly differentiated neuroendocrine carcinoma, which is large or small cell, the one of the important ways of differentiating clinically preoperatively is that most of these patients will be subjected to a metabolic scan, a cross-sectional PET scan, which is usually dependent on the somatostatin receptor concentration within the tumors. So the low-grade tumors or the well-differentiated tumors have a high concentration of somatostatin receptors, and therefore they are amenable to be picked up by DOTA-NOC or specialized PET scans, which use DOTA-NOC and DOTA-TATE. These are all the analogs of octreotide, which are picked up and they actually light up like a bulb in the PET scan, on a cross-sectional PET scan, which can be combined with multiphasic protocols so that the patient doesn't have to undergo multiple imagings. But when you deal with the neuroendocrine cancer, these are the patients who will not be picked up on a metabolic imaging of this type. You would actually do a conventional FDG PET in these patients to be picked up. So this can tell you that if you have a preoperative idea that you're dealing with a neuroendocrine tumor, and to differentiate between a tumor and a carcinoma, a metabolic scan can help you guiding in making the decisions, because if the tumor doesn't pick up the DOTA-NOC scan, then it is likely to be poorly differentiated variety with a poor prognosis. So this is one of the ways of estimating or assessing whether you're dealing with a neuroendocrine carcinoma preoperatively. Of course, biopsy is the final word, and these are the tumors which will not respond to the use of octreotide for palliative purposes. You need to consider conventional chemotherapy, usually platinum based, and or added with radiotherapy. Sometimes the resection has to be followed by adjuvant chemotherapy. I think somebody was asking this question. you have to give, but it is not a standard practice. These are all protocol based and individualized for a particular case when we are dealing with lymph node positive disease. Next. Nikhil, next. Palliative resection I've already talked about. There is interesting data which says that if you take care of the primary in a pancreatic neuroendocrine tumor, even though there is unresectable metastatic disease, the survival can be prolonged, provided you have other ancillary medical treatment going on. And this data supports consideration of surgery for the primary in patients with a low tumor burden, which is described as Ki-67 less than 10% with a good functional status. So this is again not the purview, but just I put this slide for a reason being that most consensus guidelines are recommending considering a cytoreductive surgery if 90% of the tumor burden can be safely removed and the patient is symptomatic from the disease, either because of the tumor's physical characteristics, large size, which is creating problems, or because the tumor is functional. But there is no difference related to the treatment between liver resection and TACE for long-term outcome in asymptomatic patients with more than 25% hepatic tumor involvement. So these are the caveats which you may find useful. R1 liver resections do not seem to affect liver, the long-term survival adversely, which is again something which is unique for these variety of tumors. Next. These are the guidelines which help us in assessing whether a person can, be treated with liver transplantation. But again, mind you, it is a very highly selective kind of a thing, done very, very infrequently. And the world over, not many cases have been done. But it is also known that in 5 years, the recurrence rates are quite high. 75% of these patients recur, although they have a prolonged survival and they have a good symptomatic relief if it's a functional metastatic disease to the liver. The same thing, again, reiterated. So I would just end up here by saying that you have to use appropriate use of tumor markers, cross-sectional and metabolic imaging for staging and grading of these tumors, biopsy when feasible. Active surveillance will work well for small non-functioning tumors and also in those cases where the patient is has comorbidities which precludes aggressive resection. But those tumors which are symptomatic or those which are larger than 2 centimeters often require a radical resection along with the encompassing lymph nodes. R1 resection in low-grade tumors is still justifiable, and adjuvant neoadjuvant treatment in high-grade GEP-NETs are part of research protocols and not routinely advocated. And palliative 90% debulking surgery is also recommended in certain situations where we are dealing with functioning tumors and unresectable metastasis. Liver resection for resectable liver metastasis and rarely liver transplantation for low-grade GEP-NETs have been shown to have meaningful survival. With that, I would end up here and I'd be happy to take questions. Thank you, Nikhil.
Thank you, Dr. Sujoy. Thank you, sir. So questions, like we are already running much behind time. So questions will take up in the panel somewhere in between. And Asit, quickly start.
Yeah, I think let me share my screen. Okay, so
Yeah, it's visible.
screen is visible.
Yeah.
Yeah. So I'm not sure whether Jaspriya is here. Jaspriya, have you joined?
Yeah, I'm there. I'm there.
Okay, wonderful. So we have the panel. I think what we're going to discuss in this panel is we have had 2 theoretical talks. We know the definition of GEP-NETs. We know the staging of them. We know how to grade them. While we discuss this, we will probably discuss in the light of the case, and we would also like to refocus on these concepts again. So we have this panel. Dr. Jay Mehta have has left because he had some other commitments. We have heard Dr. Sujoy. Dr. Saluja is here with us, who is the professor of GI surgery at JB Pant. We have Dr. Mudhasir, who is the medical oncologist from Fortis Noida. We have my dear friend Kapil Jamwal, who is the gastroenterologist in Artemis and one of the pioneers of EUS in Delhi, and my colleague and my dear friend Dr. Jaspriya, who is the consultant of your nuclear medicine at Max Saket. So this are some of the findings that we already know, that there has been a jump in the diagnosis of neuroendocrine tumor in last 5 decades. And this is primarily because of the advent of high-end cross-sectional imaging, CT scans and MRIs, and also widespread use of endoscopies and colonoscopies. So we are finding more and more incidentally detected NETs which are non-symptomatic. And most of the neuroendocrine tumors that we diagnose are non-functional. And functional accounts for only 10 to 35%. By functional neuroendocrine tumors, we mean those neuroendocrine tumors which secrete some hormones which can lead to symptoms. For example, insulinoma, which by producing insulin will lead to hypoglycemia and Whipple's triad, or a gastrinoma, which can lead to hypergastrin secretion leading to acidity and Zolliger-Ensel syndrome. Most of the incidentally detected and most of the neuroendocrine tumors are asymptomatic. So that's why there is a concept of whether these tumors should be followed up rather than operating. So we'll discuss this concept in detail again when we go ahead. So I'll just have a real life case which presented to us a few months back. So this is a 60-year-old lady who underwent an ultrasound for an annual health checkup. And during that checkup, the sonologist discovered a lesion which is about 2.5 into 3 centimeter. Now, this lesion is well circumscribed and it is hyperechoic, and it is located in the head of pancreas. Pancreatic duct is not dilated, CBD is not dilated, and gallbladder is normal. Now, Professor Saluja, if I may ask you here, what comes to your mind when you see this ultrasound report, and how would you proceed further in this case? Dr. Saluja?
Unmute.
Unmute.
Can you hear me?
Yeah.
Yes, we can. So, sir, with this ultrasound report, patient is in your OPD, and what is this? What is it that comes to your mind, and how you think we should proceed? Now, you are telling this for the benefit of our residents as well.
Yeah, we are finding a lesion on the head of the pancreas, which is hyperechoic. So that means it is a solid component lesion. I would like to go contrast enhanced pancreatic protocol CT in such a patient.
Right. So since this lesion is hyperechoic, so are you considering something of a non-ductal adenocarcinoma type, or does it favor any other pathology like a neuroendocrine tumor?
It could be neuroendocrine tumor. It could be acinar cell tumors, the other rare variety of pancreatic solid tumors, because PD is not dilated. It could be less likely. It could be a pancreatic cyst, which is rarer. So all these will be there. Other than adenocarcinoma, since you have a lesion which is 2.5 centimeters to 3 centimeters enlarged, and this duct is not dilated. So ductal adenocarcinoma will be lower in order. But this will require further investigation whether which kind of lesion it is.
So next investigation in your mind is triple phase CECT abdomen. Yeah. Perfect. So or a CMRI abdomen. I mean, both would be interchangeable. Some people would prefer a CT or others MRI. So you would get almost the similar kind of features in both. So this is the CT scan in your screen. If you can see this, I hope this is visible to all. So this is a lesion here, which this is an arterial phase scan, and this is a portal venous scan. So in arterial phase, you can see this lesion is well circumscribed, almost a spherical shaped lesion, and this is enhancing well on an arterial phase as compared to rest of the pancreatic parenchyma. And when you see the other portal venous phase, again, this lesion is very well demarcated as compared to rest of the pancreas. This is retaining the contrast. It is still hypovascular and hyper-enhancing as compared to rest of the pancreas in portal venous phase. And if you see the pancreas, there is no pancreatic ductal dilatation. And though I have not seen the portal venous phase here, there is no dilatation of the CBD here. Now, in light of these findings, sir, what is your impression now, and how are you going to proceed further from here?
I mean, in light of these findings, definitely a hyper-enhancing lesion is there. The pancreatic neuroendocrine tumor would be high on cards, and a GIST will also be there because they are also hypervascular tumors. Both of them would be there, and following this, we can go for some functional markers like chromogranin to know whether this is a neuroendocrine tumor, or if we have a high suspicion, we can straight away go for a Dotanak PET scan.
Perfectly. So I think since this lesion is an hypervascular lesion, for the interest of our residents, I would say this essentially rules out pancreatic ductal adenocarcinoma, which is by definition hypovascular and hypodense on CT scan as compared to rest of the parenchyma. Am I correct, sir?
Yes.
Right. So what are the essential features on CT scan which you feel can differentiate neuroendocrine tumor from pancreatic ductal adenocarcinoma? Sir, can you enumerate and can you explain these findings further?
Yeah, these tumors, the pancreatic ductal adenocarcinoma, usually they are hypovascular tumors, and they have associated ductal dilatation, and they are while these tumors which are neuroendocrine tumors are again hypervascular tumors. You will not find any ductal dilatation. Lymphadenopathy is more common with the tumors of the pancreatic adenocarcinoma. These are the findings. And then another feature is that if you have a relation with the adjacent, once the mass is large, adenocarcinoma usually infiltrates. So you will find that these tumors might give a sign of is a change in the contour in case the vascular involvement is there, while the pancreatic neuroendocrine tumors, usually these would be maintaining the contour, they would be pushing tumors. These are some important features which might help us to differentiate from adenocarcinoma.
Absolutely. So by this, I mean, only on the basis of CT scan, a well-performed CT, a phasic CT would give you a lot of idea whether you are going ahead or looking at a neuroendocrine tumor versus a ductal adenocarcinoma. So now there are certain findings in which you can possibly differentiate between a well-differentiated and a poorly differentiated neuroendocrine tumor as well. And the poorly differentiated neuroendocrine tumor would have certain findings which would you see in a pancreatic ductal adenocarcinoma. So these are the findings. If I have to enumerate size, usually a poorly differentiated NET or NECs are larger in size, more than 3 centimeter. They don't have the enhancement pattern is a little different. They usually enhance early, arterial enhancement is there, but then they wash out in the early portal venous phase. Unlike this tumor in which you saw there was contrast retention. Now you can have central necrosis. If you're seeing central necrosis, that indicates a poorly differentiated tumor or a aggressive NET. And diffusion restriction on MRI, presence of regional node and vascular involvement, again, in presence of a hypervascular lesion, points towards a poorly differentiated neuroendocrine tumor. Now we come to an important point. I mean, there are a couple of questions that has been asked by audience as well about the functional imaging. Now, Jaspriya, we would like your help here. So there are 3 terms here. We call DOTA-TATE scan, there is a DOTA-NOC scan, and there is a DOTA-TOC scan. Are these similar? There is any difference between the 3, or they are synonyms?
No, they are not synonyms, and they are different chelates. So basically the difference is the receptors. So DOTA-NOC is the one which binds to 2, 3, and 5. So that is why it is one of the most commonly used one. DOTA-TATE and DOTA-TOC are more specific for 3 and 5 and 2 and 3 respectively. So to have the lesions with maximum number of receptors, we prefer using a DOTA-NOC scan.
Right. So mostly we would end up doing a DOTA-NOC scan. That's what we do in practical, right? So if you are suspecting a neuroendocrine tumor, So
Yes.
the next workup would eventually become a functional imaging.
Right.
So as per you, should Dotanox scan be a routine in the staging workup of all neuroendocrine tumors? Should it be used selectively? How would we decide?
So if we are suspecting a neuroendocrine tumor and we still don't have a good first investigation which has been done across cross-sectional imaging, a Dotanoc imaging along with a good triple phase CT can be used as first line of investigation. But in a case where we are seeing it's already we can't, there's a good triple phase CT which does not show any lesions in liver, any nodal involvement. A Dotanox scan can be skipped in such cases because it will not add anything. Generally, in tumors, indolent tumors, where there are high chances that the patient may present with Mets, a Dotanox scan should be done. Ideally, it should be done as first imaging.
Okay, so usually in a well-differentiated tumor, say grade 1 and grade 2 NET,
Yes.
what percentage of these tumors will have a somatostatin receptor, or what would be the sensitivity of Dotanox scan in these patients?
So Dotanox scan has a very high sensitivity specificity of around 85 to 92%, and a specificity of somewhere around 95% in detecting the primary NET for G1 to G2 tumors, and a very high sensitivity specificity for the liver mets as well. It's almost around 100%.
Right. So is there any role of somatostatin receptor scintigraphy in today's era? When we have Dotanox scans, do we still need somatostatin receptor scintigraphy?
No, it's only being done at places where there's no accessibility to PET. Otherwise, DOTA scan with a good triphasic CT, a PET CT has a much better spatial resolution than SPECT, much more easily available. The imaging is done immediately after 1 hour of the scan, unlike somatostatin receptors where the patient had to wait for 2, 3, 4 days and for sequential imagings. So there's no role as of now.
So it's a investigation of past now, right?
The past, yeah.
Right. So another thing I wanted to ask you is whether the SUV values on Dotanox scan can predict the grading of the neuroendocrine tumors. Does a high DOTA avidity indicates that it is a well-differentiated grade 1 tumor versus lower SUV predicts towards poor grading, and no uptake on DOTA predicts NEC? Does it work,
does.
and what is the association?
So it does. For the higher the somatostatin receptor activity, the higher will be the SUV. So it goes more in favor of a well-differentiated. Of course, we can't differentiate much between a G1 or G2 just on the basis of scanning. But we can definitely differentiate between a well-differentiated and a poorly differentiated. More is the uptake on a Dotanox scan, more are the chances of it being well-differentiated.
Okay, so what is the role of dual tracer PET scans, a dual tracer FDG and DOTA PET? So, Dr. Sujoy, I think you have touched on this aspect probably in your talk. When would you want to have a dual tracer PET in your patient? What would be the indication in a neuroendocrine tumor?
The dual tracer is usually required when you have a diagnostic dilemma. If you have a Dotanox PET scan which is lighting up, you don't need to do a FDG PET at that point of time. But sometimes when you have a patient who has, say, occult primary, and you have a metastatic disease in the liver, which appears to be that from a neuroendocrine primary elsewhere, you might have to do both, to find where the primary is. And in certain situations, post-therapy, where there has been modulation of and use of somatostatin inhibitors, it may make a sense to have dual metabolic imaging. And the other thing I wanted to point out was that insulinomas are the one variety of pancreatic NETs where Dotanox scan is not specially sensitive, because not very sensitive, and it's not recommended.
Not
routine.
the
So it should
routine
not
DOTA knock scan. There are different DOTA chelates. That's extending, which is used for
Exandin is the one which is recommended.
Yes.
GLP-1 based
GLP-1
Right.
analogs.
chelates.
Agreed.
So that is another thing that I want.
Insuloma, it is not. So not directly is the preview of this talk, but if you are planning to operate a patient of grade 2 versus probably a grade 3 NET, and this patient has a metastatic deposit in the liver, and you are not very sure whether you want to operate this patient or not. So probably a dual tracer PET can help you make your decision.
Exactly. Yeah, sure.
Better if this patient has a good DOTA avidity versus a good FDG avidity, probably a decision making of operating this patient might help.
Yeah,
So this is probably one of the indications where you can do a dual tracer.
Yeah, in grade 2, grade 3, actually FDG and DOTA are complementary for especially in metastatic cases.
Right,
so
exactly.
That can help in the individualizing the therapy for the choice of treatment in such cases.
Right. So if a tumor has more FDG avidity, it's probably denoting a more
poorly differentiated
pattern, and you won't be very aggressive with surgical treatment with these people.
And there's a proposed scoring also for the same, which is called the NET PET score. So that also helps in deciding.
Right. So if you can elaborate a little more on that scoring, Jaspriya?
That's basically a visual assessment of both the imaging gallium DOTA knock as well as FDG. So it's scored from P1 to P5. So P1 is a higher G1 gallium uptake than FDG. And then it goes down to P5 is FDG uptake more than gallium. So it's basically a visual assessment itself.
Okay, in which you compare the FDG avidity and DOTA avidity and give a scoring.
Yeah, right. Lesion by lesion it is compared.
Okay, yeah, great. So like this patient had a DOTA PET, and if you can see, it is beautifully and vibrantly lighting up the pancreatic head. And this lesion has, there is no other uptake, and this is a localized, well-differentiated neuroendocrine tumor of the pancreas, incidentally detected in a lady. Now we come to serum assays. This, I think Dr. Jay Mehta also touched it primarily. So Kapil, if you are here, now what is the role of serum assays in these patients? So I'm not talking about functional tumors here, because if you're a functional tumor, you're going to ask for a very different set of hormonal assays. I'm talking about a non-functional neuroendocrine tumor. So if it is a pancreatic tumor, I think a chromogranin A is a standard thing that we're going to use. We can use NSE and pancreatic polypeptide. What are the pitfalls? What you think you should be careful when you're asking for the benefit of residents?
Yeah, so Asit, there are two markers which are commonly available and which we use. So one is chromogranin A and second is 5-HIAA. And these are divided based on the location of the neuroendocrine tumor. So chromogranin A denotes tumor from either a foregut or a hindgut, and 5-HIAA which shows a tumor from the midgut. So because the hindgut and the foregut doesn't contain serotonin granules, so that's why. So chromogranin A is not a marker which can be used for diagnosis, and it has shown in multiple studies. It is a marker which can be used for prognosticating or follow-up during treatment. And there are some conditions in which there can be false elevation of chromogranin A. One is high dose of PPI. A patient who's on high dose of PPI can have falsely elevated chromogranin A. And the second condition is hepatic insufficiency, and third is renal insufficiency. So in these patients, the chromogranin A can be falsely elevated. And the second point I want to tell to residents is that it is not a tumor marker for diagnosis. It is for prognostication and for follow-up during treatment. Whereas 5-HIAA is a very good marker for diagnosis of carcinoid syndrome from midgut. And the normal level is around 5 to 8 picogram per ml, and it can be increased in certain conditions like patients who are on PPIs, patients who have on some celiac or some other diets, or they have malabsorption disorder of the small bowel. And it is usually said the levels more than 50 to 100 times the upper limit of normal diagnose serotonin syndromes, and it's by a simple urine test. And some certain conditions like patients on PPIs can again this can interfere with assessment, as well as patients who are on octreotide therapy, because patients who are on these conditions are on treatment. This can interfere with the levels of 5-HA. So these are the pitfalls and associated with these tumor markers. And the function would already told. So we do this like gastrin, we do commonly for suspecting a primary stomach gastrinoma, but only thing is the same is PPI, because the PPIs may falsely elevate the levels up to you can say the normal level is up to 200 nanogram per ml, and it can go up to 900 level with the use of PPI. So we have to stop PPIs for at least 1 week to 2 weeks and shift the patient to H2 receptor antagonist before we send level of serum gastrin as well as serum chromogranin.
Wonderful, Kapil. Very important points. So at least a week before you have to stop the PPIs before you should order this.
Yeah.
And meanwhile, if patient is too symptomatic, they have to be shifted to H2 blockers.
Yeah.
Right. And secondly, not to be used as a diagnostic or a screening tool, especially chromogranin A, and 5-hydroxyindole acetic acid to be used for midgut carcinoids, small bowel carcinoids. Wonderful. Thank you. Thank you there. So we'll move on to the next slide. Oh gosh. Yeah. I think. Yeah, Kapil, again, your forte. So endoscopic ultrasound is the probably the newest kid on the block, but one of the very important modalities by which we can diagnose and grade these tumors. So first thing, I mean, I would like to ask this, Dr. Saluja, do you think that preoperative histological diagnosis is necessary in neuroendocrine tumors before you're embarking on any treatment, say surgical treatment?
No. Routinely, it is not required if you suspect, like in the case you have shown to us. If you have a patient with a pancreatic head tumor, you suspected, you got a total knock done. I would prefer that this patient will require treatment. So doing an FNA to confirm it is not going to change my management. The requirement of doing this upfront FNA is in areas where you have a large mass, you are planning some kind of what do you call a neoadjuvant treatment in some patients if you have a suspicion of adenocarcinoma. So there is some diagnostic doubt, and most of the time when we get these patients, it is because these patients land up to gastroenterologists and they do the FNA before they send the patient to us.
So there could be one specific clinical scenario where we might want an FNA. For example, if you're not looking at a radical resection, say if you want to do a enucleation for the patient I've shown, if I'm looking at enucleation, would it not be wise if I have the grading, if it is a grade 1 versus a grade 2 or grade 3? If it is a grade 2, grade 3, I would rather want to do a resectional procedure, not an enucleation procedure. Do you think this is one aspect where we can?
Yeah, no, I would think we are looking at too far-fetched thing, Asit. You say that if you are taking a tissue FNA, you are doing it, you might not representing that area. Number two, it is the size of the tumor. It is 2.5 to 3 centimeter. You really know that these patients have some kind of, when you enucleate, there will be ductal disruption. So landing up with the pancreatic fistula is also an important thing. If you are, if you think that yes, you upfront want to feel that, in that case, why not do directly a frozen section if you want to enucleate it? So I don't think it would be mandatory for me to, based on that FNA, that I would plan upfront my treatment that I'm doing an enucleation.
Fair enough.
As far as I think.
So it's routine FNA or biopsy, absolutely no. Selectively, we might case on case depending upon, right? So Kapil, what is the difference between a US guided FNAC or biopsy, and how technically different they are?
Okay, so I would like to consent with Professor Saluja that until unless a surgeon sends me a patient who is resectable for a neuroendocrine tumor for a FNA, I will not do it. There are few indications where I will like to do a USs. One is where we are not able to differentiate between PDAC versus neuroendocrine tumor. Second, what you discussed was when the surgeon is not clear whether he is going to do a enucleation versus a resection. So when the margins are very clear, close to a duct, where he wants to do a resection, but doing a surgery in such a case may land it up in a fistula. In that case, US may help. And third is when patient has functional tumor like insulinoma, and on imaging, we are not able to find any lesion. So like a CT or a PET CT or a DOTA-NOC is not able to show any lesion, and patient has the diagnostic criteria of insulinoma. In those cases, the sensitivity of US for a lesion from 2 to 4 millimeter up to 2 centimeter is very high, and we'll be able to find. And regarding your question that FNA versus biopsy, already Dr. Jay Mehta told that biopsy is much better. At the moment, what we can give you is a high end for FNA, but the tissue is not very good, which can, I think, show everything. But there are now trials which are going on where we have a biopsy forceps which have been devised, and which are being on large trials are being going on, and which are called US guided biopsy forceps. And we can take a biopsy now from that two forceps, but the larger trials have to show that they are better than FNA, and I think then we will be able to guide and help our surgical colleagues better in such cases.
Right, thank you. So the last two questions have been answered by Dr. Jay Mehta, that usually FNAC is not something which we rely upon for grading the neuroendocrine tumors. We need a biopsy, and we need a pathologist who has looked diligently into that biopsy, and specimen was adequate, that he has looked into at least 50 high power fields and then reported as less than 10 high power fields for mitotic count, and at least 200 cells, 2000 cells they have screened for reporting Chi67 index. So I think a good biopsy yield is very important before you can base your decision solely on that. Yeah. So management, right? So I think I would need the input of Dr. Sujoy and Dr. Saluja here. Resection versus enucleation. I think if there is any tumor which is amenable for enucleation, especially in pancreas, so the role of surgery is less controversial when we talk about stomach and rectum. So rectum, it will be straightforward. You have to just resect it. If it is a small tumor, less than 1 centimeter, you can do it endoscopic resection, be it ESD or EMR. If it is bigger and it is below the peritoneal refraction, you can do a transanal excision. But if lesion is more than 2 centimeter, or there are lymph nodes involved, or if this lesion is infiltrating into the muscularis propria, now here the role of US is very important. US can tell us all these findings in a rectal neuroendocrine tumor. So if there is an aggressive tumor, you have to do a resection procedure like an anterior resection or an APR, like Dr. Sujoy told in his talk. But in pancreatic lesions, there would be a case of resection versus enucleation. So Dr. Saluja, which are the tumors where you would consider enucleation, and how would you investigate these patients?
It is the standard teaching is that if the lesions are less than 2 centimeter, then these patients can be enucleated, and then the tumors which are more commonly located in the body and tail region, they are more commonly, they can be enucleated easily. You also have to have a use of intraoperative ultrasound, where you can locate the association with the ductal area. If you are suspecting any high malignancy or something like that, the case which you are showing in a patient with a non-functional neuroendocrine tumor, which is of 2.5 to 3 centimeter in size, I would err upon doing a resection rather than doing an enucleation. And that you want me to answer the other two things also?
No, I think for lap and open, I would want Dr. Sujoy to chip in. So, sir, do you think there is any difference between lap versus open for resection of neuroendocrine tumors, or rather you would prefer lap? If one has to do a lap, I think these tumors are best suited for laparoscopic pancreatic resections.
Yeah, they would be. Although I'm not a laparoscopic surgeon, I don't have any experience with lap resections. But yes, both lap enucleation and lap resection can be performed eminently for the distal tumors, and for the head tumor of this type, again, this would be okay. The only problem is that you'll be ending up with a very small or an undilated duct. And if you are a skillful laparoscopic surgeon and you're able to include that duct into anastomosis laparoscopically, then it's fine. Otherwise, it's better to do an open surgery, because you'll be able to do a better justice to the anastomotic site. That's
Agreed, sir. I think, but if you consider the biology of this disease, and so you don't have to do that aggressive lymphadenectomy as you would want to do in a ductal adenocarcinoma. I think if somebody has to venture out onto lab, these are the cases where people.
That is one option, definitely.
Yes.
And there is one controversial thing that I wanted to mention. I mean, I don't know how many of you will agree, but there is a halfway between resection and enucleation, which is you do the enucleation in a tumor of this type. I'm not recommending enucleation for such a tumor, but if you have a 2 centimeter tumor in the head, which is maybe close to the MPD, sometimes you can get away with enucleation and doing what is called a cavitojejunectomy, where you can anastomose a loop to the jejunum, of jejunum to that cavity, to take care of any pancreatic leak. We have done a few, although I would say that it's not a standard recommendation, but this is one option which can be undertaken if you want to avoid a big resection.
What if I told you that we did the same for this patient?
Oh, that's good. So that answers me my question.
Right. So the role of lymphadenectomy. Does the role of lymphadenectomy in neuroendocrine tumor any different as compared to other tumors? And would the extent of lymphadenectomy differ on the basis of the grading of the tumor? If you have a grade 1 tumor and a grade 2 tumor versus a grade 3 or an NEC, is the role of lymphadenectomy different in these two? Dr. Saluja, please.
In neuroendocrine grade 3 tumors, lymphadenectomy is done, but I think it also depends upon the size of the tumor. Also, if you have got a if you have got a Dudonok scan, you are pretty sure that there is not a spread. So doing a lymphadenectomy, standard lymphadenectomy would suffice in this tumor. It was as the size of the tumor increases, the lymph node spread is often seen in these cases. So lymphadenectomy can be included in these tumors. That is what I take.
Right. So if it is a well differentiated, especially if it is a grade 1 NET, I don't think any lymphadenectomy is required. If there are no regional lymph nodes involved on a good performed DOTA PET or a CCT, we can even avoid a lymphadenectomy. Otherwise, a regional lymphadenectomy if the nodes are present or if it is a high grade tumor. I think this is what we should be saying. Now, can observation be offered to any of these patients? And if yes, what criteria to follow? I think Dr. Sujoy touched on this briefly in his talk. I mean, what are your thoughts? Would you offer observation to any of these patients? If yes, what are those patients? Who are those patients? I would start with you, Dr. Sujoy.
Yeah, I mean, this kind of a situation can arise when you have incidentally picked up tumor, which is less than 2 centimeters in size, and you have a patient who has other comorbid conditions, and you would actually put them on an active surveillance program and decide to operate later if required. But on the other hand, if you have a younger individual with such a thing, I would be more happy to actually advocate surgery in such a situation. Whereas in an older individual with comorbid conditions, where the tumor is looking relatively less sinister, doesn't have all those malignant looking features, size is less than 2 centimeters, you would be justified to do active surveillance. But active surveillance is important because you have to put the patient who believes in the treatment, is compliant, and he's going to accept repeated imaging in the next 6 months to one and a half years, where you have to do repeated 6 monthly scanning to see whether the tumor is increasing in size. If there is an increase in size, or if the tumor crosses the 2 centimeter barrier, it's better that you offer surgery in that situation.
So if you are offering a patient observation, say this patient falls into your the criteria, if less than 2 centimeter, asymptomatic, and it's very well data avid. So if you wish to offer this patient observation, would you want to confirm that this is a low-grade tumor? It's a grade 1 NET. Would you want to do a biopsy in this patient or not?
No,
would you
not
do
in
a
this one.
US-guided biopsy on this patient?
Not in this one.
Okay, right. So as per this is the ENET's recommendations. They say in an incidentally detected asymptomatic patient who has a non-functional tumor, which is less than 2 centimeter and it is grade 1. These patients may be offered observation provided they are well informed and they are well motivated to be on regular follow-up. So this is what ENET says at present, right? So if surgery is not done due to poor risk patients, say this is a resectable neuroendocrine tumor, and you are not able to offer surgery for whatever reasons, is there any role of somatostatin analogs in these patients? Dr. Mudhasir, can you elaborate on this? Would you like to offer somatostatin analog for these patients?
Hi. Yeah, it was a fantastic discussion till now. Though I was not involved, the early stage NETs and NECs surgery is the main thing. So in this case, the question is that long-standing somatostatin analogs in a poor risk patient who is not fit for surgery. This is a very probably there is no guideline for this, so there will be very little data available for this. But if especially if the tumor is functional, so then they may get some help from the somatostatin analogs. Other than that, somatostatin analogs, other than just few trials, have not been shown that they reduce the size or So you may just keep it there, keep under observation. But if the patient is symptomatic or if the patient has functional tumor, I would like to give it.
All right. Dr. Jaspriya, is there any role of PRRT in a treatment naive patient? Would you ever consider doing this therapy for these patients?
Similarly, there is no data to say that we can give PRRT in such patients and it would be beneficial in such cases. Nothing to support as of now.
Right. So perfect.
Actually, we can talk about local ablative therapy in the pancreas.
Yes.
Like RFA or something like that, microwave, yes, which can work if you're not offering.
Those things could have worked. Rather than RFA, I think irreversible electroporation is one thing which would have worked wonderfully in this patient. These patients, if IRE would have been a wonderful tool here. Right. So now we come to adjuvant therapy. Now we don't know what is the role of adjuvant. I mean, we do, but then we want you to elaborate here. What is the role of adjuvant therapy in grade 1 and grade 2 tumors versus a grade 3 tumor, like grade 3 well differentiated grade 3 versus NEC? So do you think, and menin, in all these three conditions, if there was a tumor and I have resected it off, what is the role of adjuvant therapy? So let's begin with first class, grade 1 and grade 2 tumors.
See, grade 1 and grade 2 small tumors or kind of completely resected tumors, I don't think there is any role of any adjuvant therapy. A post surgery, as sir also said, that it will be only observation.
Perfect.
And follow up.
And what about a grade 3 neuroendocrine? Say it's a well differentiated grade 3, but Ki67 is close to 20. You have still resected it off. Would you consider giving any adjuvant therapy to this patient?
Now probably from the grade 3 well differentiated to poorly differentiated NEC, it is probably a spectrum, which I feel that there will be a kind of a spectrum of the prognosis which gets worse as the tumor gets poorly differentiated, which has been seen in many different studies that the grade 3 well differentiated have a better prognosis than neuroendocrine carcinomas. So in neuroendocrine carcinomas and grade 3 well differentiated, they are the most common recommendations say that we should be giving them the chemotherapy, adjuvant chemotherapy, just like we give in small cell lung cancers, that is the etoposide and platinum based chemotherapy for 4 to 6 cycles, depending upon the response. In very localized, which have been resected already, I would definitely go for adjuvant chemotherapy. because this is the only chance they will have, most probably. If they are fit enough for chemotherapy, I would definitely offer them chemotherapy. But and another category of patients is which are the tumors which are locally advanced. We may give them upfront chemotherapy and radiotherapy, maybe followed by a definitive surgery, probably, if they become operable after that.
Perfect. And what about menin, the mixed neuroendocrine and adeno? So these tumors are usually treated as the more aggressive part, that is the adeno part. Would you treat them
Yes,
the adjuvant therapy like adeno?
I agree with that presumption, because if see, it will also depend upon what is the neuroendocrine component, whether the neuroendocrine component is carcinoma, or is it or is it just neuroendocrine tumor or grade 1 or grade 2. Though the pathologist, I think, delved a lot on this, what are the components can be. But most probably in case of gastric, for example, in case of pancreatic, the adenocarcinoma will take lead.
Yep.
I'll think
Okay,
in more
perfect.
detail.
I think that's you have made it absolutely clear.
Can I come in, Asit?
Yeah, sure, sir.
I just wanted to just put one word about the grade 3 neuroendocrine tumors, which are actually considered as well-differentiated entities. Actually, speaking, the adjuvant recommendation is not very clear for grade 3 well-differentiated, even if you have a lymph node positive disease. But generally speaking, these tumors are supposed to be less responsive to platinum-based therapies and more responsive to things like use of everolimus, use of temozolomide, use of sunitinib, and things like that. And sometimes if they're functional, then use of long-acting octreotide. So it would be a developing area where things are not yet crystallized, but these patients are the ones who require more stringent surveillance post-surgery, which is R0 surgery if it has been done. And they have to be followed up with frequent chromogranin A estimations, frequent cross-sectional scanning. And if there is a recurrence, consider resurgery if resectable, or put them on these kind of therapies. That is what my take on it.
I agree, sir. As I said, sir, this is a kind of a spectrum. Probably the
Exactly.
grade 3 well differentiated being the most, the good prognosis, and the neuroendocrine carcinomas being the worst prognosis. And nobody will be able to actually, because these are very rare tumors. The grade 3 well differentiated neuroendocrine carcinomas, less. There are not many studies phase studies which have establish the role of adjuvant therapy, and we probably may never have those studies. So whatever is there, because if the patient is well enough, good performance status, we may give them that benefit. That is the only, there is a discussion, there is no specific recommendation. I agree with that.
Right, very well. So I think rest we have covered. We have covered rectal as well. Gastric NET was covered briefly by initially by sir about type and observation. So obviously small intestinal carcinoids will be operated almost always. So would be functional tumors. So I think that concludes our talk for this evening for the first session. I think if there are any questions, I saw in
there are questions. Asit, thank you very much.
Sir, I have one more, because in, for example, we treat the neuroendocrine carcinomas of lung, or kind of small cell carcinomas of lung, we give them prophylactic radiation to the brain, etc. So that there is no role of probably in these tumors. So it should not be offered to them. Yeah. And there are good questions, I think, in the chat box. Go ahead.
Yeah, there are many questions, so I think we'll take up, I mean, for lack of time, we'll just take the ones which are not been covered or which are very important. And so Dr. Shivayak has asked any particular number of lymph nodes to be resected. So Dr. Sujoy?
Nothing standard. Nothing
standard. Yeah. And so Dr. Manish Jain has asked that should we do the biopsy pre-op if it's not changing the plan? So I think we have covered that. Manish, you can come in if you have anything specific to add there. And Somebody has asked for the role of radiation. Dr. Mudhasir, you have commented that. So can you elaborate there, Dr. Mudhasir?
Sir, locally advanced, or which are upfront unresectable virtually, like T3 or T4, T3N1 lesions, which are upfront, which we know that it is T3N1, it is high grade, and or it is like a T4 lesion, high grade. So then probably in those things we can actually treat them just like a small cell lung, that we can treat them with chemoradiation, but not in the early, probably not in the grade 1 and grade 2.
Yeah, thank you. So Dr. Shivayak has asked about non-functioning asymptomatic net size criteria for resection. So we've already discussed that. Lymph nodes we've discussed. So Nidhi asked about DOTA-NOC as primary investigation, and we have already discussed that. This is discussed. PPI has been discussed. So Sudhir asked about how can you diagnose an extra-abdominal metastasis if you do a triple phase CT, say in a patient of carcinoid. So we have told that like panelists have already enumerated upon that point that DOTA-NOC should be done in most of the patient. Chemo,
there is a this thing caveat that CT is best done for chest imaging. For picking up metastatic disease, apparently CT is supposed to be better than MRI and other cross-sectional imaging. Of course, PET scan, if it is positive, yes.
Yeah. So any role of neoadjuvant treatment, Dr. Nidhi has asked, Dr. Mudhasir?
As I said, sir, in the tumors which are not upfront operable, resectable, especially the grade 3 and neuroendocrine carcinomas, there is the only role of neoadjuvant.
Yeah. And
there is one interesting case scenario where you would want. So can we use PRRT for downstaging the tumors for resection if they are deemed unresectable initially? For example, you have a head mass and it is infiltrating into the SMV and you want to downstage it. Can we use PRRT in this setting? Jaspriya, can you have your thoughts on this?
Yeah, there are few studies, although we have lesser number of patients, which have shown a very good response to PRRT, and the unresectable tumor has become resectable post 3 or 4 cycles of PRRT. So it can be tried,
so I think
for pancreatic NET.
Yeah, otherwise I don't think there is any conversion therapy as a neoadjuvant therapy for neuroendocrine tumors, but this is probably one which can be used if you think that you want to convert the patient from unresectable to resectable.
Yeah. And Dr. Varun Bajaj has asked if diagnosis is not in doubt, whether IOUS is better than EUS. Dr. Sujoy, I think you can elaborate upon that.
IOS is when you have already made a decision for surgery and you don't have access to EUS. IOS is obviously an important tool during the surgery. But nowadays, like I'm talking in response to, with reference to insulinomas, whenever we work up these patients, we try to have 2 radiological or complementary investigations which confirm the location of the tumor before we take these patients up for surgery. So intraoperatively, again, we add intraoperative ultrasound also. So I won't say that they are exclusive investigations. You may still need to do intraoperative ultrasound, even if you have an endoscopic ultrasound. And if you don't have an endoscopic ultrasound, then IOS is obviously the only recourse that you can have.
Yeah, very well said, sir. And Dr. Manish Jain has asked what investigations are required to rule out functional NET in head of pancreas. Also, please tell about need for ruling out MEN syndrome. Dr. Kapil, you want to take that?
So there are specific tests like hormonal tests which are done, like we have to send assays for, like patient has suspected carcinoma, then gastrin level, then if we are suspecting somatostatinoma, GFRoma, we have to send those levels. And depending upon that, we decide the diagnosis and follow for treatment. Regarding, what was the second question?
Please tell about need for ruling out MEN syndrome.
MEN syndrome is patients, normally the neuroendocrine tumors are sporadic if we have a well-defined family history of in families, so then we have to rule out for Men's syndrome. But normally 60 to 70% are sporadic, so they're not in families.
Yeah.
So before I close, I want to add that normally I was at Mayo for some time, Mayo Clinic, Rochester, and they have a large cohort of neuroendocrine referral, tumor referral. So their policy is to attack. Even a 1 centimeter tumor, 2 centimeter tumor, if suppose it's not a pancreatic tumor, it's a GI tumor, so they resect it, even it's a non-functional. So they are not in a policy of following it. So they have been, because of the large history, so they have followed and made a protocol that they will remove all tumors if it is resectable, either whether it is surgically or endoscopically.
Okay. And so Dr. Nidhi has asked, what is the prognosis of localized well-differentiated NET? So I think the prognosis is very good if you resect them, and long-term outcome are better. And is there any difference between non-functional or functional tumor outcome? Anyone?
Functional tumors have a better long-term survival. Non-functional tumors have a poorer survival, largely because of the fact that the functional tumors are picked up earlier.
Yeah.
Agreed.
So
regarding men, Nikhil, I just wanted to add one, that if you have a gastrinoma as the functional presentation, then many people would like to screen for a MEN1 syndrome. Insulinomas are most often sporadic, but gastrinomas are commonly associated with MEN1 syndrome. And generally, the thing to be done is the calcium levels and to look for a cross-sectional scan of the head to rule out a pituitary tumor. These 2-3 things would help you in ruling out a MEN1 syndrome.
Yeah.
Dr. Kapil sir, one just, somebody said that, how to look for a functional pancreatic tumor. Yeah. So you enumerated some of them, but should we do it in all patients to just say that it is just non-functional, or should we should the workup be just on the lines of, as Dr. Asit, actually went through the, evaluation of pancreatic tumor?
Yeah, so Dr. Mudhasir, ideally we should do everything, but we have to see our patient resources and our availability. So these normally hormone levels are not done everywhere.
Exactly.
So these are done in special labs and special centers only. Exactly. So and depending upon the incidence, so most commonly the incidence is the GEP-NETs, which are in the proximal foregut, as well as the pancreatic neuroendocrine tumors are most common. We can have, but depending on the referral center, I think they will also say that they've seen very few cases of the other functional tumors like somatostatinoma, GFRoma, or very rare tumors. So that's why it's not included in the algorithm evaluation. That's why, because of the level, as well as the level of evaluation, as well as the number of cases which present to us clinically.
So would that make a difference? For example, if there's a tumor and there is we are suspecting that it may be functional, it may not be. If it is functional, that means, there will be some symptoms.
Yeah.
If there are no symptoms, then we should assume it as that it is non-functional, isn't it?
Yes. So that's why it's called non-functional.
Exactly. So we do not need to look for these enzyme levels, these hormonal levels. These are only in cases of then when you are suspecting something, you will direct your testing on that.
So suppose you find a disease which is localized, and on imaging you find that it's a PET, a neuroendocrine tumor. So the best thing is do a surgery.
Yes.
And it will show what type of tumor it is. Suppose you find multiple lesion, metastatic lesion, and there is non-functional. Then the problem is, then you will do a biopsy.
Yes.
And then you will do. So the thing is, stage of disease as well as what do you find at diagnosis will decide. The patient who have typical symptoms, then is functional. Then that's why the hormonal level is associated more with functional disorder rather than based on imaging.
Agreed.
Yeah. Absolutely.
Did we do biopsy, EUS biopsy?
No, I told you, if surgeon refers to us, if unresectable, there's some dilemma or there's some problem. Otherwise, if resectable, it should be resected. No need of fiddling it.
Okay, sure.
Yeah. So Dr. Manish Chen has asked about role of capecitabine and temozolomide in well-differentiated G3-NET. Dr. Mudhasir?
So as a adjuvant therapy, I don't know whether there's any data for that. For he said G3, grade
Yeah,
3.
G3, well differentiated.
I don't know whether there's any data for that. There must be, I think, if he has written a question, but I have not come across any data which says that adjuvant, in case of adjuvant, it can be given. Yeah.
Manish, you can come in the discussion. No, okay. So again, we have Dr. Sudhir who have asked us, in addition to anti-secretory action, long-acting SSRIs have an anti-proliferative and anti-neoplastic action. So any patient on observation protocol should be offered these.
No, observation means observation. Then you don't
Yeah.
do anything. That's self-explanatory.
Yeah.
Don't use treatment like that.
Yeah. So we have almost taken up most of the questions. So that brings us to our like finishing of this, and thank you, my panelists. It was a very, very wonderful discussion. Thank you, Asit. And we hope to continue. I mean, we hope, no, we will continue this activity. So it will be a bi-monthly program. It will be on 1st and 3rd of every Wednesday. And I would request the students and participants to register so that we can send them the link to the recorded videos, and we can send them all the upcoming webisode or webinar, what we call them. And also there is a question box there. So if they have any questions, please put it in that box so that we can plan for them. We can incorporate them in the talk. We can incorporate them in our panel discussion. So we'll be able to have much better answers to these questions. With this, I would like to thank everyone and conclude this. Thank you very much.
Thank you.
Thank you, one and all. Thanks.
Thanks a lot.
And see
Bye,
you
good
after
night.
2 weeks.
Yeah, good night. See you after 2 weeks. Yeah, bye-bye.